Module 3 includes discussion of the management principles of opioid use disorder. Also discuss our suggestions for talking with the patient with an opioid use disorder. And we talk about the importance of harm reduction as well as the continued treatment of the pain disorder. Opioid use disorder is a chronic illness. As we spoke about in the earlier modules, primary prevention involves careful prescribing of pain medications. And secondary prevention involves intervening when there appears to be the beginning of risky behavior, as Dr. Friedmann just described. In this module, we will begin to discuss tertiary prevention of opioid use disorder using medication addiction treatment, or what we call MAT. MAT helps patients interrupt use, enter into remission, and return to remission when they relapse. With opioid use disorder, MAT has been shown over decades to be life-saving. It helps patients prevent infectious complications and death from overdose. This is not the case with abstinence or non-medication treatment, including short-term detox or rehab. These have never been shown effective in treating opiate use disorder long-term and may actually increase the likelihood of overdose death due to the elimination of tolerance. In interrupting intravenous opioid use, MAT reduces the risk of numerous complications, including endocarditis, cellulitis, osteomyelitis, scarring of the veins, HIV infection, and viral hepatitis. And in all cases of opioid use, it reduces the risk of overdose death. A harm reduction approach says to a patient, I care enough to meet you where you're at to reduce your risk for infection and overdose. Harm reduction involves implementing strategies to reduce the negative consequences of drug use and acknowledging there's a continuum of drug-using behaviors and some are safer than others. This includes utilizing nasal naloxone to prevent overdose and also providing information on needle exchange and teaching safe needle use to prevent infection for those who are not fully in remission or who have relapsed. A harm reduction approach treats patients with dignity, and conversations include asking permission first. People feel respected when asked permission and are more likely to be open. The approach also involves using non-stigmatizing language, as Dr. Friedmann beautifully described in the earlier module.
Yeah, so when we talk about conveying the dignity of the patient, that is something that asking permission does. It conveys respect for them, for their autonomy. It empowers them. They do have the ability to say, no, I don't really want to talk about this. I have never, in my 25 plus years being in this field, I have never had a patient say no. And what this does, in combination with using non-stigmatizing approaches, particularly language, that develops therapeutic alliance. You are on the patient's side. You are working together towards the goal, whatever the goal is. And numerous studies have shown that having a strong therapeutic alliance with the patient really is the most important factor in helping them achieve behavioral change.
I completely agree. Thank you for that. Medications are optimally paired also with counseling and social support to address co-occurring mental health concerns and social problems. This is important because substance use disorder is highly associated with social exclusion, isolation, joblessness, and housing insecurity. So again, just reinforcing why it's so important to treat patients with respect and dignity. I want to add a brief example of a case where harm reduction model really hit home for me. When we first began our Suboxone program, I had a patient who sniffed heroin and smoked crack cocaine. She was dependent on both, and she did well in our Suboxone program and entered into remission for her opiate use disorder, though she continued to use cocaine. After about a year of intensifying support through counseling and an intensive outpatient program, we discharged her from our Suboxone program and let her know she was welcome to come back when she was ready to be fully sober or substance-free. But over the ensuing 6 months off of medication addiction treatment, she relapsed with opioids, but now had moved from sniffing heroin to IV drug use with mixed heroin and cocaine, and her risk of death markedly increased. Fortunately, she's now back in our program. She continues to smoke crack cocaine, and we are trying to address that. And she's working to re-enter remission for opioid use disorder, but fortunately also she's no longer using needles. Through a harm reduction lens, I now see treating her various forms of substance use as no different from treating hypertension and diabetes, for example. I would never think of stopping antihypertensives on a patient drinking a liter of Coca-Cola a day who doesn't have control of their sugars. Nor should I have stopped Suboxone in someone in full remission from opiate use disorder, even though they continue to use cocaine. This slide with a graph showing control of the chronic condition and stage of treatment beautifully illustrates the case that I just relayed to you. And it just shows that while somebody is on treatment, their chronic condition is controlled. And when they go off of the treatment, they lose control of this condition, whether it be hypertension, whether it be diabetes or medication addiction treatment. So in terms of management principles, as Dr. Friedmann already relayed, it's so important to use a non-judgmental approach. Make sure to set up expectations upfront with a written treatment agreement that allows for pill or film counts and urine toxicology screens. And make sure to emphasize progress and use shared problem solving. Use a contingency management model to respond to a patient doing well with longer duration prescriptions. And on the other hand, respond to a patient with relapsed substance use by shortening the interval of the prescription from 14 days to 7 days, for example, and add support with counseling and even a recovery coach if available. With continued substance use, discuss with the patient intensifying care, which could include an intensive outpatient program, for example. Important harm reduction strategies for the patient and his or her close family and friends include counseling on safe needle use, needle exchange, and safe disposal of needles. We've had family members in our clinic who've come in with needle sticks because needles were not disposed of safely. And it is critical to let patients know where they can dispose of their needles at home in the interim and then in the community. It also includes secure storage of medication for addiction treatment in the home. The last thing we want is for children or people without opiate tolerance to get in contact with these medications. It is beneficial as well to screen for hepatitis B immunity and to offer vaccination to anybody not immune.
The idea that you are treating the person holistically, all of their conditions, their risk for hepatitis, their vaccine needs, again, that conveys your respect for their personhood, and again, important in developing therapeutic alliance, and again, not extra to their recovery, but really an important addition to it.
Thank you, Dr. Friedmann. I also, as a primary care doctor, would say that that's why I think treating addiction in the primary care setting is so important, because we treat the whole patient. And to the patient, that's really important. They may come in with pain issues or diabetes or other issues, then we address the whole patient and all the problems they're dealing with. So with overdose prevention, it is helpful to involve a family or close friend, anyone who might be looking out for the patient when he is using opioids. Important advice specifically for the patient includes not mixing opioids with other drugs, sedatives, or alcohol. And also being aware that abstinence lowers tolerance. Some of the highest risk times for overdose death are when someone relapses after being late for injectable naltrexone or Vivitrol, after being released from prison, and also in the immediate postpartum period after refraining from use during pregnancy. These times are critical, and it is so important for people with opiate use disorder to know that these are risky times. The other important counseling is to let patients know they should try a test dose of whatever substance they are going to use, and even use a fentanyl indicator strip if available. Both are very important because of the large amount of inexpensive, highly potent fentanyl and even carfentanil on the street. Caution patients never to use alone. With fentanyl, the risk of overdose death is in minutes. It does not help if a family member is downstairs. Keep nasal naloxone on hand And remember to continue to encourage patients to use medication addiction treatment to help enter into long-term remission. Family members and close friends can be taught how to respond in the event of an overdose. Discuss with them how to recognize overdose, make sure they know to call 911 immediately for help, and how to administer nasal naloxone. There are many ways one can prescribe naloxone, and one of them is nasal naloxone or nasal Narcan, which is the one we use. In the syllabus, you'll find details on how to prescribe other forms of naloxone. With fentanyl on the uptick, responding to overdose must be quick, whereas with heroin, one might have had up to an hour to respond. With fentanyl, it is only minutes. In addition, the fentanyl effect can last much longer, beyond the duration of 2 doses of nasal naloxone. So the initial call to 911 is absolutely essential. So with all this, Dr. Friedmann, I wanted to ask you how you treat pain, especially acute pain, in patients that are on medication addiction treatment.
Yeah, so that's a great question that folks are often very concerned about. It really depends on the type of medication addiction treatment they're on. It's typically folks who have chronic pain syndromes, naltrexone is relatively contraindicated. For those who are on agonist treatment, either with methadone or buprenorphine, you need to treat their opioid debt to prevent withdrawal. So the baseline amount of methadone that you're given once a day is not enough to treat their pain. That's often the mistake. You need to add medication on top of that. What's true with these medications also is that the analgesic effect is much shorter acting, so you'll need to, whereas, for example, you give buprenorphine once a day, for the addiction treatment, you may need to give it 3 or 4 times a day to treat pain. So what we often do for folks who are on buprenorphine who are, say, going to undergo a dental extraction or something is we will continue their buprenorphine, but we will divide their dose 3 times a day, maybe increase the dose slightly, making it 3 times a day. Some folks do add another short-acting opioid because the thinking is that not all of the receptors are occupied all the time, and that some short-acting opioid for pain control may be useful. And as we mentioned, this is different for naltrexone. For those folks, you probably, if they're going to undergo a painful procedure, you'll probably need to use other modalities for pain management, or take them off the naltrexone, wait till in an elective process. It can be overridden by anesthesiologists using high doses of pharmaceutical fentanyl, but typically it's more challenging with naltrexone.
Management of opioid use disorder should take into account the patient's readiness for change. Approach the patient with concern and compassion, as behavioral change is very hard, and many have relapsed in the past and lack hope. Use patient-centered, non-stigmatizing language, incorporate harm reduction and motivational principles, and continue to treat pain conditions as needed.